what that means. Hopefully. Okay, let's go. All right, we have a busy day ahead of us. Couple very brief announcements. Those who wanted to see Dr. Gurley's session this morning, I know it got cut short. We have rescheduled him for this afternoon at 2 o'clock up in the paddock room, which is up on the second floor. And that's the session of classifications by antibodies. You have evaluations that were in your bag when you registered. And one of the evaluations is about hotel considerations. We look at those very carefully, and we really spend a lot of time making sure that the hotel that we select can best accommodate the needs of our members. So your suggestions and comments there are very important to us, and I hope you'll spend the time to turn those in before you leave. You can mail them back to TMA if you need to. We also have an overall conference evaluation where you can evaluate all the sessions, and we also look at those very closely, and that does shape the program for the next year. Of course, there are evaluations at the individual sessions the last day and today and tomorrow morning. If you want to fill those out, again, they're very helpful to us, and I really hope that you will do that. The other announcement I need to make is that a couple people who participated across the hall in the IBM studies, the folks over there need a couple of you to come back just to sign consent forms. And I just want to ask that Charles Unger, James Bates, Ann Eagleston, Boyd Kimball, and Jill Sondker. I think, Jill, your session this afternoon, they want to move it up because they're going to shut down a little bit earlier. So when we're done here, if you have a chance to get across the hall and take care of that, I know they will appreciate it. We are going to have our medical panel get underway in a minute here. Before we do that, as you know, we did the 20 for 20 horse contest yesterday, and we saw the Kentucky Derby from 2003. Today we're going to see the race from 2008, and again, the top three finishers are the numbers that will be still live going to the final race at lunchtime today. So if AV is ready.
Off and running in the Kentucky Derby. Fast start for Cool Coleman, who takes the lead up the inside, but quickly out of center. There goes Bob Blackjack to take a short lead. Big Brown getting a good position on the extreme outside with the filly 8 Bells. A Thunder past the Twin Spires for the first time. Long shot, Bob Blackjack leads it clear by nearly 2 lengths now. Challenged on the outside by Recapture the Glory with Adriano and Cowboy Cal. And there goes Big Brown, and he's moving steadily with 8 Bells on the inside, and Cool Coleman rounding the first turn. The opening quarter was 23 and 4/5 seconds on that first turn. Bob Blackjack leads it clear by 2 lengths now. And he's stalked on the outside by Cowboy Cal. Just a link back racing in second with Recapture the Glory right there in third. Cool Coleman settles down fourth. The filly, 8 Bells racing fifth. Big Brown, the favorite, 3.5 lengths off the pace. Z Fortune between horses. Tail Bacati skimming the fence and inching up along the inside. Gallego's got about 7 lengths to make up. A couple lengths farther back now to Big Truck, who's followed up by Mamba, who's stuck down along the inside and moving 3 wide. Here comes Court Vision with a half mile to run. Opening halftime was 47 seconds flat. Bob Blackjack is confronted now from the outside. And here comes Cowboy Cal to tackle him. And 8 Bells is right there with a fighting chance. Recapture the Glory. And here comes Big Brown. And he's swooping powerfully 5 wide on the far outside. Tail of Bacati's in with a fighting chance. 5 lengths off the pace. From the back of the pack, here comes Z Humor gaining ground. Along with Colonel John. He's kicked it in again, but he's 7 wide as they turn for home. And Big Brown makes a big move. And he takes the lead. Big Brown is opened up now by 3. The game filly, 8 Bells, trying to run him down the final furlong. It's Big Brown. He's gone clear. Big Brown and kept the solo by 4 lengths. The game filly second on the inside, 8 Bells, but Big Brown is a superstar. He'll win the Kentucky Derby. Big Brown wins by 5. 8 Bells ran second. Finishing up third was Dennis of Cork, and then Tail of Bacati. The time 2:01 and 4.
Okay, there's your excitement for the morning. That was to wake you up. Okay. So they came in the numbers 25 and 16, and they're the results right there. Thank you, Nate. So only one person had picked number 20, and that is Alexander. And only one person picked number 16, and that is Carla Stevenson. And number 5 came in third yesterday. So those are the numbers that are still live for the final race at lunchtime today. The other thing I did want to mention, we had planned to have seating by disease type for breakfast this morning. Instead, we're going to do that tomorrow morning. I know some of you have asked about that. So you have an opportunity to meet with those who you were with in the Get Acquainted sessions on Thursday. And so we'll be doing that then. I would like to ask the chair of the board, Augie DeAugustinis, to come up, and he will introduce the moderator for our medical panel. We are allowing about an hour, 45 minutes for this. We've asked the panelists to limit their remarks to no more than 10 minutes. And we're going to hopefully have enough time to ask a good number of questions before we need to leave here, say around 10:45 or so.
Thank you, Bob. Good morning. Is everyone enjoying the conference so far? This has been the best conference. This is actually only my 5th conference since I've only been diagnosed for 6 years. But this is by far the best conference, the most well-attended, the best presentations, and I'm anxiously looking forward for the rest of today, because now we get to hear from the pros from Dover, so to speak. That goes back to MASH, by the way, for any movie buffs in there. Wanted to ask a question first before I introduce our board. How many of you, in the process of coming up with your diagnosis, experienced running into a doctor that said, I really don't know that much about myositis? Is there anybody in here that may have had that issue? Yeah, I think most of us have. So to help you all out, we have gathered together here the top experts in the field of myositis. And if you stop and think about it, without our medical advisory board, which are comprised of top researchers from really around the globe, without them, Myositis Association would really be just an association of people who share the same illness. However, with our medical advisory board, they take TMA up to an entirely new level, in a level where we can have an impact in the world of myositis. We're making progress, and this marks our 20th year of that progress. So, without me cutting into any more of their time, because we know that doctors love to talk as well, I am going to introduce our moderator for this segment, Dr. David Fiorentino. He's a dermatologist from the Stanford University School of Medicine. So let's give him a warm welcome.
Great, thanks so much, Augie. Well, I think Big Brown needs the applause, not me. So welcome everybody. I know this is sort of the medical panel part of this meeting is one of the highlights for the medical advisory board, as well as probably hopefully for the patients as well. So for the next hour and a half, hopefully you'll get a chance to get a sense of what it is all that excites us about myositis, why, and I think each of us have a different story, and we're probably approaching it for slightly different reasons, but I think the basis for all of us is that we want to improve patient care for people who are affected with myositis. And so what you'll hear is we'll go down the line with the members of our medical advisory board, and that includes myself, and we can talk for 5 or so minutes, hopefully no more. I'm supposed to have the cane out and pull you guys off stage if you talk too much, so don't make me do that, please. And you can, it'll be sort of a bit of a monologue, so there's probably some time for questions, maybe from me, 1 or 2 I'll try to think of interesting questions to try to ask that may be relevant for you guys. So I'll start, and again, I'm Dave Fiorentino. I am the only lonely dermatologist here on the panel. I actually operate a clinic in conjunction with a rheumatologist, however, over at Stanford, where we specialize in seeing patients with mostly, as you can imagine, dermatomyositis because of the obvious skin involvement with that disease. And so I'm an immunologist by training. I did have a doctorate in immunology before I did my dermatology training. And what got me so interested in this disease was partly just that I was amazed how many people were misdiagnosed and how commonly even dermatomyositis went under the radar. And patients would come into clinic with a diagnosis of psoriasis or eczema or lupus commonly. And the patients ended up having dermatomyositis. And so I got very interested in that, and in particular, we're very interested in trying to actually, it's amazing, but we're in 2013, but still describe this disease better in terms of how patients can look, because it's such a different disease, and I'm sure each of you have a different story for how myositis has affected you. Well, even within dermatomyositis, that can be so different from patient to patient. And so what we're very interested in is trying to understand ways to classify patients into more groups that look alike, homogeneous groups that is very important for the research that we want to do. Without being able to group patients, it's very difficult to understand what you're studying. And also for clinical trials, for therapeutics, you need to have a way to basically have a group of patients that you think are fairly similar. And if you're going to test a therapeutic. So one of the things I'm very interested in at Stanford is not only looking at skin manifestations, because that is obviously one of the organs that's involved in some of the myositis diseases, but also what the skin can tell us about things that patients want to know is, what's my long-term prognosis? Am I likely to go into remission? Do I have a cancer? What's my likelihood that my lungs will be involved? And so those are things we think that the skin can help tell us. And in addition, I do a lot of work on actually looking at the autoimmune responses in dermatomyositis. So as you know, many of these diseases patients have autoantibodies in their blood, and it turns out that the autoantibodies can be used to classify patients somewhat. And we're interested in trying to understand more about what is the role of these very specific immune responses, and can that ultimately lead us to a safer therapy for myositis. So that's kind of what we're doing right now at Stanford, is trying to really use these antibodies to classify patients, and we do clinical trials as well, like many of the others here. So that's what we do. I guess we can just start at the end of the panel. Steve, I'll ask everybody on the board here just to introduce themselves and tell us obviously where you're from. I think what got you interested in myositis, and in particular, and what sort of, if you have any future goals or dreams, what your ultimate dream would be in terms of how your life's going to play out to solve this disease. So we'll start at the end here with Steve.
I'm Steve Greenberg from Harvard Medical School in Boston. I became interested in myositis research a number of years out from my training. After I completed my training, I was in practice for 6 or 7 years, and during that time I saw a lot of patients with myositis and was quite frustrated in the poor understanding of some of these diseases, particularly inclusion body myositis, and the limitations of treatments that we had. So I changed directions and went back to a university-based practice and developed a research program around studying all forms of myositis, but became increasingly focused on inclusion body myositis and dermatomyositis for various reasons. And my laboratory over the last 10 years or so has pursued a number of approaches to try and understand these diseases and ultimately to improve the diagnosis of them and to develop therapies for them. Some of the things that I've been pleased to be able to accomplish so far have been better understanding of certain mechanisms in dermatomyositis that are occurring, and in inclusion body myositis, the development of a blood test for diagnosis of inclusion body myositis, which is starting just recently to gain experience and to have its utility or usefulness defined. I've also been involved in trying to push forth a number of clinical trials. One of them is a clinical trial of inclusion body myositis that I spoke about this morning and I'm speaking again about later on today.
Hi, my name is Roop Tandon, and I'm from University of Vermont in the northeast of the country. Some people ask me where Vermont is. I am a trained internist and a neurologist and neuromuscular physician. I direct a neuromuscular program at the University of Vermont. And I got into neuromuscular disease because my mentor in my fellowship was a gentleman by the name of Dr. Walter Bradley, who provided one of the initial classifications of inflammatory muscle disease. And his mentor was Sir John Walton in England, who was a very famous neurologist who did work and research in inflammatory muscle disorders. So I also direct the ALS Center, and I see a lot of patients with IBM who come to see me who have been misdiagnosed. And I think that the TMA did a survey a few years ago that showed that up to 15% of patients with IBM may have been told that they have ALS or Lou Gehrig's disease. So I see a lot of patients with IBM who are referred to me as ALS, and then they get the correct diagnosis on that. I have a substantial clinical population base of patients with not only ALS but also inflammatory muscle disease. And I have been involved in new drug development in ALS, and I hope to be able to take that to patients with muscle disorders as well. Thank you.
So, Roop, I was just going to interrupt here. Just curious about the misdiagnosis issue with IBM and ALS. Do you feel like that is something that is going to be in the near future that we can overcome that? And what are the barriers to actually making a more accurate and timely diagnosis, do you think, for inclusion body myositis?
Yeah, I think that the important thing is that we need to educate people about IBM and its clinical manifestations. We need to educate people about ALS and how that might present. So education is important. We need to make sure that we not only educate the public, but also general physicians, general practitioners, other folks who see patients with these disorders. And then if they have a problem with the diagnosis, if things don't sort of fit right, then they should hopefully seek a specialist advice with respect to achieving a diagnosis.
Good morning. My name is Alan Pestronk. I'm from Washington University in St. Louis, and since we're introducing ourselves today, the first thing I'll say is go St. Louis Cardinals. I participate in a neuromuscular clinic at WashU in St. Louis, where we see patients with all kinds of types of muscle and nerve diseases, including many different kinds of myositis. Our research group focuses on two areas. One is with Chris Weil and Matt Harms and Tim Miller, the genetic and hereditary possible basis of different immune and hereditary disorders, and where the group that was, again, for the second time, thank you all, collecting saliva samples and slowly learning more and more about that component of the disease. My own personal interest is my thought that right now we can actually do a lot better in diagnosing these diseases. One way of doing that, as Dr. Fiorentino mentioned, is by looking at antibodies, but my particular interest is looking at the muscle pathology, and it's my thesis that right now muscle pathologists can do much better than they're actually doing to make accurate diagnoses. And my research involves looking at muscle biopsies in different ways that we can do now that it's my theory and evidence that we can make better predictions about, as muscle pathologists, about what's going to happen to the patient. And as examples of that, we can predict by looking through the microscope if you have an immune or inflammatory myopathy, whether you're likely to have a lung disease. Maybe one day we can predict how likely you are to have cancer. We can probably right now predict, just again by looking at the muscle pathology, whether or not you're likely to respond to immunomodulating agents like corticosteroids. And so in the process of analyzing the muscle pathology like that, what we're trying to do is to slowly propose ways that doctors can look at the muscle biopsy in a little bit more sophisticated ways than most pathology doctors look now, and then be more useful in bringing that information back to the patient's doctors and then to you guys, so they can give you better information about how to take care of you. And so again, it's my hope for the future that with even better ways of combining examining patients, looking at their blood tests and antibodies, and looking at their muscle biopsy, we can take care of patients and one day even treat inclusion body myositis better than we do now. Thank you.
Can I ask you a question, Alan? Can I ask you a question? Just, so I think that's, Dr. Pastronka is very understated. You're looking at one of the premier muscle, this man has looked at more muscle tissue in an intelligent way than I'd say anyone on this planet. And he is got a very sensitive eye. And my question is regarding getting more out of it. It's interesting that this is a technique, right, we've used for years, right? And there's still more to be explored. And so I'm wondering how much of this is an art that you need to, really have the experience of someone like yourself that in some ways can't be taught. And ultimately, what are the chances that this could become, tests can be developed that are actually quite simple and make an earlier, better, timely diagnosis just using the right tools?
So, again, it's my thesis that this is, all of medicine is somewhat of an art, but I think that most or everything that I see through the microscope when we're looking at muscle on Saturday mornings can be taught to other doctors. It's simply a matter of having a muscle pathology lab doing the adequate number and types of tests on the biopsy when they come in on into the lab in the first place, and then just looking for what the patterns of abnormality are. So my general concept is that muscle is not just hamburger. That if you look inside muscle, there's muscle tissue, there's connective tissue that holds the muscle together, and there are vessels, and different forms of inflammatory and immune myopathies attack different parts of the muscle, and I don't think it's that complicated to look at the muscle and see what's affected and then make these predictions.
I just think it's fascinating that probably people think the muscle biopsy should be something that was perfected 50 years ago, but there's still so much in there, so much information in there if you have a careful eye. So.
And hopefully skin biopsies in the same way.
Right.
Good morning. My name is Zarif Shah-Henk. I'm from the Ohio State University, Columbus, Ohio. To be more specific, there's a question, I think. Oh, I'm sorry. I thought maybe there was a question for you. To be more specific, currently our laboratories are located at the Nationwide Children's Hospital Research Center, which is part of the Ohio State University. By training, I'm a neuromuscular disease specialist. I'm also the director of the clinical and experimental neuromuscular laboratories. So besides providing diagnostic service and giving clinical care to the patients, my laboratory is involved in analyzing preclinical material from animals and also involved in the analyzing the muscle tissue from the gene therapy studies that we have been conducting. I work with Jerry Mendel, who has been my mentor in the past, and I'm also the co-investigator for FDA-approved gene therapy, follistatin gene therapy on inclusion by the myositis and Becker muscular dystrophy. I can just briefly tell you a little bit. We made some progress finally after going back and forth to FDA. We have injected one muscle, quadriceps muscle on the one side on 3 IBM individuals and used the low dose because this was a requirement from the FDA. Since we observed no adverse events and there was no safety concerns, FDA gave us the permit to skip the intermediate dose, and we are currently recruiting for the high dose bilateral quadriceps injections, and hopefully, we will be able to tell you about results, our results in the next myositis meeting. My laboratory is also involved in understanding the pathobiology of both nerve and muscle disorders, and currently I'm exploring whether or not there is an impairment in the regeneration in inclusion by the myositis, and also trying to find ways of improving the regeneration in the muscle, which perhaps will lead to future treatment options in this disorder. This is an amazing group of people, and I'm very honored to be part of it. Thank you.
Dr. Sank, I was just curious for the follistatin trial. Maybe some of the folks here would be curious regarding that trial. How many more patients would be planned to be enrolled in the high dose? And if that was successful, what are the plans for the future for that therapy?
We are planning to enroll, which is in the process right now, 6 patients, IBM patients, they will receive the high dose to both legs, because from the Becker muscular dystrophy intermediate trial, we were very happy to see that there was clearly very encouraging results for efficacy for the intermediate, and we are doing the enrollment for the high dose right now in both disorders.
The high dose, if that was successful, and then what would the
the purpose of this study actually to improve the to improve the ambulation, because this is a direct injection to the quadriceps muscle, and to keep patients ambulatory as long as we could. So this is not a systemic therapy, although we know that follistatin is a circulating protein once it's injected locally into the muscle, and there may be some wider effects, improvements in the strength. It is regionally, and we have some evidence for that too. We're hoping that that depends on all the, obviously, the resources to see if this could, become a larger clinical trial and we can enroll more patients. So.
Good morning. I have a very long South Indian name. It's called Kanyaboina Nagaraju, but people call me Raju. So, I'm an immunologist by training, and after completing PhD, I wanted to work on autoimmune diseases. So, first things that came into my mind is rheumatoid arthritis and lupus. Like many of you and a lot of other physicians, I never heard about myositis. So I was looking for the labs. I came across Dr. Paul Plott's laboratory at NIH, and he invited me to join and do research on myositis, and his advice helped me quite a bit even till to date. So for the last 18 years or so, this is the disease that I think every day and want to learn more what is happening, how the muscle weakness occurs. As I said, I'm a basic scientist interested to create mouse models to replicate this disease so that I can test new drugs, new therapies. So those experiments in 2008 led to the identification of novel class of drugs, and you all know about prednisone, and it works, but how the side effects are horrible. So almost every organ in the body is affected by this. So by collaborating with a medicinal chemist who worked at Pfizer, so we stumbled on and identified this new class of drugs that we preserve only the beneficial effects and virtually eliminated all the side effects of these drugs. So we did this lot of mouse experiments and toxicity studies, and I'm happy to say that in the February 2014, we will do the safety trials, the phase 1 human trials with this new class of drugs. I'm hoping that one day we will replace prednisone. Thank you.
That sounds pretty exciting. Good morning. My name's Mark Gorley. I'm an adult rheumatologist. Why do I say adult rheumatologist as opposed to a pediatric rheumatologist? And Dave, you asked us about maybe what some of our goals or dreams might be. Well, I dream of a day, because I work at the National Institutes of Health and I'm a government employee, that one day this great nation will have leaders who can work together and solve problems. And not shut the doors and make us not do what we're here to do, and that is to really help you. So that said, I was a program director of training at the NIAMS, the Arthritis and Musculoskeletal and Skin Disease Institute, who trains rheumatologists. But like Raju, I had a mentor whose name was Paul Plotz, and Paul Plotz has really done a lot for myositis, and he had an offspring, and his name is Fred Miller, where Fred Miller and I were fellows together. And there's another fellow, her name is Lisa Ryder. So we all work together. And one of my personal interests came one day when I think that they might be here, is a person came and had what's called inclusion body myositis, something you know about. Well, it turned out there was a large family, so we started looking at the genes of this family, and through this meeting we've identified several other families, and we're interested in studying the genes of those people. Also working with Fred Miller and Lisa Ryder, who work with the Environmental Autoimmunity Group, we're interested in studying patients to look at how the environment interacts with your illness. So there are a couple studies you should know. One is, if you have the illness and your brother or sister who does not have the illness within 4 years of age and within 4 years of disease onset, we'd like to talk to you because we have 1 billion questions we want to ask you to try to find the answers to the environment and what might have gone on. Also, some of you have this weird disease called synthetase syndrome. And there's a new protocol who wants to find patients within 2 years of onset to ask you 2 billion questions about what might be going on and what in the interaction is going on in the environment to cause your illness. Lastly, you should all know what the National Institutes of Health is. It's a large funding agency for a lot of research, but also it's your nation's hospital. And we can provide second consultations there, third, fourth, whatever. And people come and they contact me and we make an arrangement so that you come to the NIH and we put you through all the roles and rigors of being seen to try to come up with an answer for undiagnosed diseases or difficult diseases. And that's all at no charge, thanks to you taxpayers' money. So that's what the NIH does, and I'm very happy to be here with you today. And I guess as an aside, sometimes I can serve as a first responder.
So Mark, that was great. Just questions, I mean, the question about environment and disease comes up quite a bit in our clinic, I'm sure, as well as yours and everyone here on this panel. Can you just tell us a little bit about, I mean, are there any things that have been shown that we really feel are environmental factors that have really been shown to be involved in myositis, and what can the patient do about that if knowing these things?
Well, we want to live in a protected, sterile environment, not exposed to anything. But no, that aside, studying the environment and disease is a very, very difficult thing because there's so many interactions. And when you say, why do you get this disease? We all say, well, it's because part of your genes in the environment and something happened. Maybe you got a virus and then you got sick. But the environment, there are a few things that we know that are associated with the diseases, and some of them are medicines. Some of them are chemicals, some might be the sun, and those all, have an impact on potentially triggering or aggravating or driving the disease process. And, what can we do about that? Well, trust me, with a sunscreen, that's a good thing to do, and I think all dermatologists harp on that quite a bit. And really, I think, you use common sense when you're working around chemicals and other things that, we think might be toxic, and to treat them in the way that they probably should be. But I think, that's a big area of research, and it's going to be a very difficult answer to find, and it's going to be a gazillion different things that are out there.
Yeah, do you think someday, if we know enough about the triggers, we can avoid these diseases by just avoiding the triggers?
That's a great question, and maybe yes in some, and maybe no with others.
Good morning. Can you hear me? Yeah. I'm Lisa Christopher Stein. I am the co-director of the Johns Hopkins Myositis Center, and I see a lot of familiar faces. I really like coming here every year to see all of you. First, I was thinking that Paul Plotz's ears must be ringing, because when we ask or are asked why we do what we do, I think it's sort of, for me, a series of chance opportunities. And so the way that I became interested in myositis is I'm a rheumatologist by training, and I was doing my fellowship at Johns Hopkins, and I was studying lupus, and fascinating disease, and a cousin really to many of these diseases, in my opinion. And in walked one particular patient who I see in the room, who really changed the way I started thinking about myositis. She actually had lung disease as one of the major parts of her presentation of her illness, and I had to educate myself. And so through this rare diagnosis, which now has become commonplace in my world, of the anti-synthetase syndrome, my interest was piqued. And then I was sent to work with Dr. Paul Plotz at the NIH. And he really, as a mentor, showed me all that we know and so much that we don't. And so for the last, to do the math, almost 12 years, I've dedicated my life academically and personally to the pursuit of understanding this disease better. What I do, and I'm a clinician by training, but what I love about Johns Hopkins is the translational approach. And what that means is we look in the lab, but then translate back to the patient. And so it's that beauty of seeing science translated to your clinical care. The things that I'm interested in now, in addition to clinical trials, include my new interest in looking at the heart, early cardiovascular disease, which is seen in the cousins to your diseases like lupus, rheumatoid arthritis. So there's accelerated atherosclerosis in those diseases, and I'm looking carefully in people like you. I'm also interested in the way the heart, as a muscle, may actually be affected more than we've appreciated previously. And I've teamed up with cardiologists at Hopkins to do this. And so our early preliminary work looks like we have, I think, stumbled onto something, and hopefully will translate to your clinical care in the future. Also very interested, but I don't have the answer yet, to calcinosis. And this has become my personal quest because I don't understand it. I've been, unfortunately, I've not been able to treat it the way I like, and I want to make it my personal mission before I retire to figure out how we can treat it better and hopefully prevent it. I also want to thank my co-panelists. In addition to all of you, my patients become my teachers. The co-panelists here have taught me so much. I mean, the likes of some of the giants in the field that are absolutely understated at this, in this panelist. I can actually thank every one of them for teaching me about this disease, and most importantly, I thank you because I learn every single day. I'd also like to make one plug in that our Myositis Center has grown. I'm privileged to work at a place where we really do dedicate all of our time to looking at muscle disease. We've recently been able to hire on 2 new faculty, and I'm happy to report, I think as of today, I'm not sure how long I can say this, there's no longer a 4-month wait, so I can actually see patients a little more efficiently, and that may be the greatest improvement that we've made in the last year of trying to make appointments for all of you more efficient. So I look forward to seeing some of you at the conference, and I thank all of you for coming to learn more about your disease, and it's a privilege to care for you. Thank you.
So that's great, Lisa. It's good to have. 2 years ago, I was here with Lisa, and she could barely speak. She had some kind of awful infection. I think there was a golf ball in your throat, and it was just, you looked so sick. So it's great to see you feeling better. But Lisa is someone, for those of you who don't know, who's trained in rheumatology, but really is always trying to overextend herself to understand other specialties, which is really great. I mean, she really wants to understand how neurologists look at this disease, and how dermatologists look at this disease, and you know, I think that's actually really important. It's great to have multiple specialists who see you, but to have, I think, the need to have our multiple disciplines understand how the other discipline is looking at this elephant, I think is a really important, an important concept. And I think Lisa is one of those people who really espouses the fact that we need to get together. And that's why this is so interesting, because we have dermatologists, neurologists, rheumatologists here all at this meeting talking about what we see. And I just, you know, want to thank Lisa. And is there anything in particular, Lisa, do you feel like for the patients, I mean, where, you know, that they may be, any advantage that you want to say that of having another specialty look at their disease, that they may be, that may be giving them an, you know, an extra?
Yeah, maybe. So I have an unusual lens in that, and I think some of the confusion is that patients believe when they come to our center, they'll necessarily see all of us, which is not necessarily true. In general, it's a rheumatologist or a neurologist, and if necessary, pulmonology, and then all of the other folks like physical therapy, et cetera, that see the patient. From my own personal experience, actually, I'll make one comment that probably the most quoted paper I've written is not in scientific literature, but more of a review, and it's entitled Neurologists Are from Mars, Rheumatologists Are from Venus. I did borrow the title. I actually went to a meeting recently in Amsterdam, and the paper was on that's how they started the meeting. I thought, well, I've arrived. Apparently someone's listening. So I think maybe just to say that it might be beneficial at times. I do think that one informs the other. Dr. Andy Mammon, who's the co-director of our center, has taught me a lot about the way neurologists look at the disease. So while I don't have a great answer for who should necessarily see one subspecialist or the other, I'd invite you to try to have them, if you see more than one, to have them speak to each other, learn from each other, and maybe agree with each other, which is difficult in any medical specialty. I'm sure you have figured this out. It's true, you know, in my own discipline. But so I would say that medical science, for sure, I think, is furthered by the learning across both of those specialties. One last example I'll give you is recently at, as you may be aware, it's because of the cross-discipline nature of our Center for Neurology and Rheumatology, we were able to describe a certain subset of patients who develop an autoimmune form of myopathy that is clearly associated, whether or not it's causal, it's a question, associated with statin use. And it was, you know, there's a large backstory that takes more than 2 minutes to tell you, but the brief background is that really without the back and forth of the way neurologists and rheumatologists are educated and the way we see these diseases, I don't think either of us would have figured it out. So I think together, a coordinated approach, and maybe as the patient, your job is to try to have the rheumatologist and neurologist play nicely in the sandbox, and the dermatologist would be nice. And I'm not sure I have great advice for that, but from a scientific standpoint, it certainly benefits you.
How do I follow that one? Wow. Well, my name is Christina Charles Showman. I am from the University of California in Los Angeles. And several years ago, I was referred to young women from a very famous lung transplant physician. Both of these women were being evaluated at UCLA for lung transplants. And when I saw them, it was a very bad day for me. Both of them had clear histories of dermatomyositis, clear skin findings that had been going on for 15 years. And they had been talking to their doctors, and their doctors hadn't been listening. And now they needed new lungs. And that was a turning point for me. I was told at the time when I talked to others in the rheumatology area that no one did myositis at UCLA, and there was no one to work with. I didn't listen to them. I'm very happy to say we now have a growing myositis program at UCLA. We have a research cohort of nearly 150 patients growing. We collect blood, RNA, DNA, muscle when we can. And it has been very rewarding last several years. I was telling some of my colleagues last night in our discussions, I was in the hospital rounding on the service, the rheumatology service, a few weeks ago, and a case was presented to me of a 50-year-old woman, very weak, had been in another hospital for a month or two. Challenging case, we didn't know what to do. She's about to be put on a ventilator for respiratory muscle weakness. We didn't have all the data we needed, but I had the experience from you that it became a very easy case. We treated her. She did not go on the ventilator. And the joy in the face of herself, her son, her father, that's what makes my day. That's what makes me do what I do. And so I thank you for that and for the life that I lead because of being able to treat you. In terms of research, the last several years, I've kind of transitioned my research in the area of atherosclerosis to how that might be very useful in patients with myositis. As Lisa mentioned, patients with myositis do have an increased risk of atherosclerosis. And we did some work a couple years ago just asking myositis experts, what do you do with regard to treating patients with myositis and protecting their heart and treating them with statins that everybody's afraid of that are going to hurt the muscle? We found out some interesting things, that this can't be ignored, and it's actually most myositis experts don't ignore it. Some things in the lab that we have been doing recently involve the so-called good cholesterol, which is very important in protecting blood vessels. And patients with dermatomyositis in particular have a lot of damage to the blood vessels that may be driving the muscle disease and probably the skin disease. And so we found some very interesting findings that I'm hopeful in the future may lead us to different mechanisms and different therapeutics, again, not prednisone, to treat dermatomyositis. So I thank you all for giving me the opportunity to do what I do.
Can I ask a question?
Before I start sobbing.
Yeah. Right. So the good cholesterol, which is really, and Christina's really, I think what you're working on is very fascinating, which is how the good cholesterol basically can be a protective molecule for us and for our blood vessels and probably other tissues as well. If there really is a problem with patients in dermatomyositis with their cholesterol, their good cholesterol, is there anything that you know now enough to say to the patients, what does that mean we should do about our lifestyle, or should we be exercising more, should we be eating better, or I'm just curious how that your knowledge might impact patients right now.
Yeah, it's a very interesting question, and I'm happy to say that there is some data that suggests when we say good cholesterol, we're thinking of the cholesterol, but it's actually a very complex protein which has functions to protect the blood vessels. But there's some data that has been published suggesting that exercise does improve the function of the good cholesterol. And certainly there's been a lot of work done by Ingrid Lundenberg and others in the myositis field that exercise may be beneficial to the muscles. So yes, there is some data that exercise may also benefit the good cholesterol function. Absolutely.
Yep.
Can you correlate this good cholesterol, dermatomyositis, and ridding the body of free radicals? Can you comment on that?
Oh, that's an interesting question. So, go ahead. Go ahead.
I don't know if you. Oh.
So the question is relating the good cholesterol, dermatomyositis, and free radicals. I don't know exactly the definition of free radicals, but to me that implies oxidative stress and something that I study called oxidative phospholipids. And HDL's job, one of them, is to bind these oxidized phospholipids and get rid of them from the body. And the oxidized phospholipids are very damaging to the blood vessels. And so our goal is to better understand how HDL does that so that we can kind of move towards a therapeutic that could make it do it better and bind the oxidized phospholipids better and maybe protect the blood vessels and some of the damage to the muscle. That doesn't get at what initiated the problem, but it gets at protecting the blood vessels and perhaps protecting further problem.
Hi, my name's Brian Feldman. I'm a pediatrician and a rheumatologist, and I work at the Hospital for Sick Children, Sick Kids Hospital in Toronto in Canada. And we started our myositis clinic there in the early 90s. I'm sure this is true all over the world, but certainly in Toronto, our patients and our families are very enthusiastic about research, so we have a large research program and a lot of projects going on at all times. And we've got some exciting new projects. We're studying new ways of doing magnetic resonance imaging, MRI, to better diagnose muscle disease in children and to diagnose it earlier and in a more sophisticated way. We're looking at the genes that determine how children respond to different types of treatments, so that by knowing what their genes are, we can match treatments to them that will work better and have fewer side effects. Along with a group that we started a number of years ago called the CARA group, that's the Childhood Arthritis and Rheumatology Research Alliance. It's about 200 pediatric rheumatologists across North America. We're studying the standard treatments that we use in childhood dermatomyositis to see which ones work best, so that the best treatments will be available to children all over North America and hopefully all over the world. And most excitingly for us right now is that the Myositis Association has sponsored us to study in children who are doing reasonably well but are still weak. We're studying creatine supplementation and using very sophisticated MRI studies and exercise studies to see whether creatine, which is what a lot of athletes take to improve their strength and performance, will improve the strength of the muscles of children with dermatomyositis. And thanks to the Myositis Association for that. So we're a very active program in Toronto, one of the bigger programs, and very enthusiastic about the work that's being done. I think we're really making big strides and moving forward. Thank you.
Hello, I'm Sue Maylard. I'm a physiotherapist from Great Ormond Street Hospital in London, and I specialise in children with juvenile dermatomyositis. I started working with these children about 22 years ago, and initially my remit was to not touch the children until the doctors had done their job and the disease was quiet. Unfortunately, I was constantly being handed children who couldn't move, who were very stiff and unable to lead a normal life. And I actually didn't feel that that was a sensible way forwards for these children. So I started with my team looking at a different way of providing physiotherapy, and providing physiotherapy right at the very beginning of their disease in order to prevent these loss of range of movement and this disability. And my research project was based around proving that that was safe, which we did do, and we have now completely changed our program for managing these young people. Unfortunately, during this phase, we met a young man very late on in his disease, and we were unable to help him live. But his family very kindly donated a large amount of money to help us set up a biomarker and cohort study specifically for juvenile dermatomyositis in the UK and Ireland. And this has now been going for about 10 years. We have about 400 children recruited to this study, and so it's the largest study in Europe related to children with dermatomyositis. And so part of that study, not only have we looked at disease profiles, but we're also looking at myositis-specific antibodies. We've been looking at MRIs and how we score MRIs in order to help make diagnoses. We've been looking at skin scores in order to make sure that we're also assessing all of the important components related to skin disease. We've been looking at muscle biopsy scoring systems so that actually, again, the diagnosis can be made much more easily for these young people and therefore treatment started. And we're also part of a really big European project called SHARE, which is single hub access for pediatric rheumatology across Europe. It's a bit of a mouthful. But basically the idea is across Europe, the way that these young people are managed is quite different. So this project is pulling together everybody's experiences and ideas, and we're going to try and make guidelines towards ensuring that everybody receives the same standard of care and the same input, and that's both with assessment and diagnosis and medical and therapy interventions. And so that work is ongoing. So thank you.
Sue, can I ask you a question about sorry, just physical therapy, physiotherapy? This is echoing a question that Dr. Christopher Stein asked, similar to what she asked you yesterday in our scientific symposium. But I'm just curious, I'm sure, at least we run into problems with this all the time, that patients who come from areas where there aren't maybe physical therapists who really understand these diseases that well. Are there any resources that patients can access, whether that be on the web, internet, that would be ways to sort of access somebody, or videos, or people, just wondering about ways people who don't have access to a physical therapist, that they can basically, move forward on some of this stuff, even if they don't have a local physiotherapist who's that knowledgeable in the disease? Or what would you recommend? Is there, for those types of patients? I know that's a hard question, but is there anything that patients can do?
Well, somebody came to me yesterday and actually made the suggestion that I worked with the TMA to provide something on the website that actually enabled people to access some information, maybe for their physical therapist, but also for themselves, because I understand that there's very limited resources. But I think there's just generally very limited resources for online advice throughout the whole world. So that would be a piece of work that could and should be done. In Europe, there's not a great amount of advice out there either. We have our own website for the juvenile dermatomyositis cohort study through Great Ormond Street Hospital, but again, we have limited information. It's a piece of work that should and could be done. But I guess, from my perspective, the important factor is that there's always two components to muscle weakness. Some of it's your disease and some of it's deconditioning because you can't use your body. And so maximizing or reducing the deconditioned component will actually have a positive effect on your overall functioning. And I think that's often therapists are very scared about doing anything if they don't understand it. And that, for me, is certainly in UK, the message I'm forever putting out there is don't be scared, try and maximize everybody's individual potential.
Hi, my name's Steve Yetterberg. I'm a rheumatologist at Mayo Clinic in Rochester, Minnesota. And I've enjoyed, this is the last of my 6 years on the board. I've got to admit that I've enjoyed all of them being with you. I got into this because as a trainee in rheumatology, I happened to end up in a laboratory that was doing virology research. It was a rheumatologist who was a virologist, and my very first project looked at interferon in autoimmune disease, something that was about 2-3 decades ahead of its time. And then somebody else in the lab was doing some work with a virus that caused muscle trouble in mice, and I sort of stumbled into that project, and it seems how a lot of things happen, that there's serendipity in a lot that goes on. Fast forward now 2+ decades, and no laboratory, but I'm seeing patients almost all the time, and have the joy of seeing a lot of people with myositis. It's been a challenge. I tend to get involved with other people's projects. I help collect blood for people who are interested in studying interferon and other things. The other thing that I do is that I'm the practice chair for our division. And what we try to do is look at ways to expedite and be more efficient in the care of patients. So making sure that as we see patients and are taking care of them, that we're collecting data that can be looked at for studies. And we'll leave it at that.